at the Sagicor Cave Hill School of Business and Management, located at the University of the West Indies Cave Hill campus, we meet the needs of the upwardly mobile professionals. Our business school functions in an evolving global space where the need to have that competitive edge distinguishes you as a professional. Our academic curriculum offers a variety of programs that gives you that edge. We offer our students a doctorate in business administration. Then, there's our executive masters in business administration. Our Sagicor Cave Hill School of Business and Management is for you. Enroll now.
Welcome to the Sagicor Cave Hill School of Business and Management webinar series entitled COVID-19, Debunking Myths of the Jab. My name is Kenneth Connell and I am Deputy Dean of Internationalization and Outreach in the triple accredited Faculty of Medical Sciences here at the Cave Hill campus. We have an exciting panel joining us this evening. But first of all, let me begin by thanking you, our virtual audience, from joining us here on Zoom or Facebook or whatever modality you're using to join us on this live webinar. The world has been crippled by COVID-19, the pandemic, but there is hope at the end of a very long tunnel. We often hear of life versus livelihood and a slow recovery with standard measures in place and also new interventions to assist this. Vaccines are one such intervention, and therefore the title of this evening's session. So what's unique about vaccines? To put things in perspective, they are one of the few therapeutic interventions that are given to healthy individuals. Think about it, these people have no disease at all usually. And also they're given to an entire population. So not just one or two individuals or even a group of individuals, but the aim is to vaccinate as many people in the society as possible. Of course, there are issues of inequities and inequalities. And of course, because of the information tsunami that's out there, there's also conspiracy theories and the whole anti-vaxxer movement. Vaccines' effectiveness really are measured after the vaccine has been distributed. But we have data for vaccine efficacy as well as safety. And this evening's panelists will discuss some of those issues, including the behavioral science and business of vaccines, right through to the immunology, clinical science, and regional procurement of vaccines. Beginning with the director of the Sagicor Cave Hill School of Business and Management, I'm going to introduce Professor Justin Robinson. He is a national of St. Vincent and the Grenadines. It's the first time I'm knowing that. And is currently head of the Department of Economics at the University Cave Hill campus. He obtained his PhD in finance from the University of Manchester, United Kingdom, and he holds an MSc in finance and econometrics from the Florida International University and a BSc in management studies right here from the Cave Hill campus. Professor Robinson's research interests are capital markets in developing countries, public finance, financial risk management, and corporate finance in developing countries. Professor Robinson currently serves as the director of the Central Bank of Barbados and first president of the Barbados Museum and Historical Society. And moving on to our next panelist, Dr. Karen Broome. Dr. Broome is a physician and public health practitioner who has worked in the Ministry of Health and Wellness now, Barbados, for more than 20 years. She received her medical degree from the University of the West Indies in '97 and her master's in public health, from the University of the West Indies Mona campus in 2006. In April 2020, Dr. Broome accepted an assignment with the Pan American Health Organization as advisor immunization for the Caribbean region. And during this time, she has assisted countries in the region to strengthen national immunization programs in the context of COVID-19 and the introduction and deployment of COVID-19 vaccines. Welcome, Dr. Broome. Our next panelist, Dr. Joy St. John, is no stranger to Barbados. She rose in the ranks of public health in Barbados in 1994 to become the first Barbadian Chief Medical Officer of Barbados in 2005. Dr. St. John held the position of International Health Regulations Focal Point, Liaison Officer for Barbados, and sat on the QEH Board, the NCD Commission, and the Board of the Barbados Water Authority, among many others. Dr. St. John also represented Barbados and the executive board on the executive board of the WHO, and then became the first Caribbean person to chair the executive board from 2012 to 2013. She's had 2 stints with other organizations during the 12 years as CMO, and she was senior advisor to WHO, supporting the co-facilitators of the UNGA review of the high-level summit of NCDs in 2014. Welcome, Dr. St. John. Dr. Michelle Reece is an assistant professor in the Department of Public Health, College of Health and Human Services at the Western Kentucky University in Bowling Green, and her lectures and courses include international healthcare, healthcare systems, public health administration, healthcare management and policy, and strategic marketing and management of healthcare organizations. Dr. Reece is a Barbadian and a graduate of the St. Michael and the Lord Schools. Her research focuses on health equity, community and behavioral science, and minority health for special interest in refugee and immigrant health. Welcome home, Dr. Reece, virtually. And finally, Dr. Kim Quimby. Dr. Quimby is a clinician scientist who graduated with a Bachelor of Medicine and Surgery from the UWI in 2001 and a Master's in Immunology from King's College London in 2006. She returned to Barbados in 2007, where she joined the GA, George Allen Chronic Disease Research Center, GACDRC, the UWI, as a lecturer in immunology, responsible for delivering modules to 1st to 4th year medical students. She gained her PhD in 2009, and Dr. Quimby has presented outcomes of her research at multiple local, regional, international scientific meetings. She's chair of the UWI, Barbados Association of Medical Practitioners, CME Committee, and a member of the Barbados Medical Council Committee, CME Committee. She's also the curriculum coordinator of the Caribbean Cytometry and Analytical Society. So ladies and gentlemen, we have a very distinguished panel of scholars and more importantly, practitioners in their fields. And I'm going to invite Professor Robinson to be the first batsman up with his presentation. Thank you, Professor Robinson.
Okay. Thank you, Dr. Connell. Good evening to fellow panelists and good evening to our audience. Okay. Just trying to get my slides moving here. Okay, just making sure I get my slides moving here. Just give me a second. Okay, some reason my slides seem, okay, good.
We can see them moving now.
Okay, so good evening. So we are all faced with this dramatic crisis of biblical proportions. And if you look at the slide there, we see the spread of COVID-19 cases and deaths all across the globe. And what a difference a year makes. In May 2020, and I think Dr. Connell was our sole panelist when the School of Business had a panel on the COVID-19 pandemic. We had 25 cases in Antigua and Barbuda with 3 deaths. As of yesterday, we had 598 cases in Antigua with 13 deaths. In Barbados, we had 81 cases with 7 deaths. we stood at 2,772 and 31 cases, with 31 deaths. So the pandemic has really ramped up across our region. Now, back then in May, my tagline, which I was very proud of, is that the Caribbean was on the front line of the economic fallout from COVID, but we had been spared the ravages of the health crisis. That has clearly changed. We are now faced with a double whammy. We have an emerging health crisis and a worsening economic crisis. Now, most of our Caribbean countries are heavily tourism dependent, and the COVID-19 pandemic has devastated tourism. In 2020, we saw an 84% drop in tourist arrivals in the Asia Pacific region, 75%, 75, 74, 69. Tourism has been completely devastated, which has had negative consequences for our region. So global tourism suffered its worst year on record in 2020, with a 74% decline. If we compare this to the 2009 global crisis, there was a 4% decline. And this has placed jobs and livelihoods on the line. Now, the impact on the Caribbean has just been devastating. So if we look at our broadest measure of how well an economy is doing, the gross domestic product, we have a sea of red. A 22% decline in GDP in Antigua and Barbuda, 21.5% in St. Kitts, 18.6 in St. Lucia, 18.4 in Barbados. I mean, I live and work in Barbados, and the last time the Barbados economy was this size was more than 15 years ago. So we are facing a massive economic crisis. There's been a tremendous impact on government finances. So in 2019, Guyana had a government deficit of 2.8%. That is now at 9.6%. In 2019, Jamaica ran a surplus of 0.91% of GDP. Now it's a 10.7% deficit. Across the board, it's a sea of growing deficits. If you were to put that in business terms, that's the equivalent of losses. If you were going to put this in household terms, this is the gap between what you're earning and what you've spent. Now, when the pandemic started, the well-known consulting firm McKinsey created this framework which looked at some possible scenarios for the economy in terms of how the pandemic may have unfolded. What the reality is that we are in the B column of this. That's our reality in the Caribbean and many parts of the world, where the public health response and intervention, social distancing, and all of those things we've all gotten used to have been inadequate to control the spread of the virus. And we are faced with a prolonged economic downturn. What economists hope for is what we call sort of V-shaped recessions. You come down and you go back up rapidly. That is not what we are facing. Now, this brings us again to the topic of our seminar, that the outstanding progress made by the scientific community has brought several vaccines to our doorstep in a record time. The effort must now pass from the scientific community to an urgent collaborative effort led by government and policymakers, healthcare professionals, private sector, and civil society. I have tried to give you a short glimpse of the scale of the economic crisis that the Caribbean is facing. Those high-level numbers don't tell you half of the reality. We have record levels of unemployment. Where I live and work here in Barbados, on my drive home on a Friday, I pass several small shops where people make their living selling food, having their weekly karaoke's. They cannot exist. They cannot do that business. So lives are at risk and livelihoods. Now, done correctly, vaccine delivery efforts have the potential to save lives, restore livelihoods, and allow us to start the next normal. Our interventions to date have been inadequate to slow the pace of the pandemic, and we are facing a health and economic crisis. And the vaccines are our best effort, and I think we cannot afford to fail. And I will close by introducing this model, what we call, so those of us in business economics who look at this as, in many ways, a logistics supply chain kind of effort. And what I would want to urge is that the vaccination initiative is so important to our lives and livelihoods and a chance to return to normal that we need as comprehensive a framework as possible. And I introduced this so-called 6A model, which seeks to look at the vaccination effort across the full spectrum of activities. We need vaccines to be available. They need to be administrable. They need to be acceptable. They need to be accessible, affordable, and accountable. For us to have a successful effort and achieve that around that 80% that we need for herd immunity, policymakers need this holistic perspective and make sure we are ticking all the boxes across that 6A perspective. I'm hoping that as we go through the discussion today, we get to look at all the factors under each of these headings. So thank you very much, Ken, and that's my opening spiel. You're still muted.
Thank you very much, Prof.
The most commonly used word in 2020-21 is "you are still muted," or phrase.
And you need to turn off your mic. Okay, so we're not open for questions, but I was struck by the last illustration and the availability in the 6A approach. Seems like almost the responsibility of scientists. And you kind of pass this baton over to the other 5 A's. Who are the other stakeholders? You kind of insinuated that one was obviously government, but who are the other stakeholders involved?
Okay, again, other key stakeholders would be healthcare professionals, organizations, across the spectrum of civil society. Because I think big questions are, and because I'm in a business school, how does my company deal with this vaccination effort? Do I seek to incentivize my employees to do it? So it's really all of civil society, because again, storage of vaccines, that might be a different capacity. The whole area of vaccine acceptance is one of the areas that I am particularly interested in as somebody who works in behavioral economics. What are the tools for persuading persons? Because this is not a mandatory vaccine. Because I think in Barbados and the region, one of our challenges is that we've not really done an adult vaccination program, certainly not in my lifetime. And the techniques of persuasion, because we know the record of adult vaccination programs around the rest of the world. So I really see that as all civil society. And I fear that if we keep this in a government healthcare box, we might not be able to tick all of those 6 A's, which are needed if we are going to have this necessary and effective campaign.
Thank you very much. And it certainly will be dissected more in the discussion. So over to the second presenter, Dr. Quimby, who's going to go into some detailed immunology, and it's already bringing back bad memories of medical school, but I'm sure she's going to simplify it. Dr. Quimby, over to you.
Thank you, Dr. Connell. Okay, so thank you for those introductions, Dr. Robinson. And now I'll be telling you about the immune response in relation to vaccines. So first, I'm going to talk about the immune response to COVID virus. And then on my second slide, I'll tell you about the immune response to the vaccines. And then on my final slide, I'll just give you an introduction to the vaccines that are out there. So I think if you've been reading the literature or you've been on any social media platform, you know the COVID-19 life cycle. So here's the SARS-CoV-2 virus. And we see these all important spike proteins that you hear so much about. So the spike proteins bind to the ACE2 receptor, which is on our human cells. And the virus uses that receptor to enter our cells. Once within the cell, the virus releases its mRNA. So RNA is like the genetic code for the virus, just like how humans have DNA. So my DNA will say that I'll be relatively short, brown with crunchy hair. So then this RNA says what the virus will look like. The RNA then uses our own machinery in our cells. So this is the Golgi apparatus. And it uses our machinery to make proteins out of this RNA. So it rebuilds the virus basically, and then the virus buds off, usually killing the cell in the process. So what's the immune response to this virus? So I just want to introduce you to 3 basic cell types. Here we have the dendritic cells, and these are phagocytes. Basically, that means they're eating cells. They'll just eat the virus. So that's what that does. It takes the virus inside. It then cuts the virus up into pieces, and it presents it, this presenting molecule, to the second cell type I want you to remember, the T cells. So these T cells are helping cells. They help the rest of the immune system to become activated. So these T cells will in various ways activate the dendritic cells. So the dendritic cells will go back and look for more virus and eat them, destroying them. They also activate the B cells. And you can see here on the surface of the B cells, they have these Y-shaped molecules. These are antibodies or immunoglobulins. You would have read or heard a lot about those as well. So once the B cells are activated, they multiply a lot. You know, sometimes when you get an infection, you kind of feel the lymph nodes under your neck or behind your ears swelling up. That's because your immune system is becoming activated. The B cells are going in there and they're multiplying a lot, producing a lot of themselves so they can fight the infection. So once they multiply, they release a lot of these antibodies. And these antibodies will go bind to the virus and will kill the virus in several different mechanisms. So there you have the immune response to the virus. Let's now turn our attention to the vaccines. So there are different types of vaccines, but I'll introduce you here to the 3 major types that are out there. We have the viral vector. So that's the AstraZeneca vaccine, the Sputnik, which is a Russian vaccine, and Janssen from Johnson & Johnson. We have the mRNA vaccine, so that's Moderna and Pfizer. And we have the vaccine that is part of the protein or the outer shell. So it can either be a protein subunit, like the Novavax, or the inactivated virus. So it's the coronavirus that's been heat killed or UV killed. It's not, cannot replicate, and that's the Sinovac. So let's start by looking at the mRNA vaccine. So the Moderna and BioNTech, it has the mRNA and it's surrounded by a lipid bilayer. So just kind of like 2 layers of fat. And that's surrounded the mRNA to protect it. Now the mRNA within this lipid bilayer, it does not code for the entire coronavirus. It only codes for the spike protein. And that's important because that's the protein that it uses to enter the cell. So we want to neutralize that particular protein. So we don't need anything else. Only the mRNA for the spike protein is in there. So what do dendritic cells do? Dendritic cells are phagocytic. They eat the vaccine, basically. And the process is the same as if it were an infection. So the mRNA is released. It uses our own apparatus to make more of itself, but it's not making the full virus because we do not have the code for the full virus. We only have the code for the spike protein. The spike protein is that's presented on the presenter molecule and it's recognized by the T cell. That's correct. The T cell will help the dendritic cell, but it also helps the B cell. And the B cell will produce their antibodies. And if you get infected a second time around, but if you get infected now with the real virus, the antibodies are there already preformed and they will destroy the virus. So you give your vaccination to build up your immune system so that if you see the infection subsequently, you already have your immune system primed. So that's the mRNA, Moderna, Pfizer, BioNTech vaccines. Let's now look at the viral vectors. So this virus here, that's not the SARS virus. This is an adenovirus, another flu virus. So they've taken the flu virus and they've gutted it. So they've taken the insides of the virus out and they have put in the RNA for the coronavirus, but actually it's DNA. They put in the DNA for the coronavirus. They don't put in RNA, they put in DNA. DNA is easier to work with. the RNA vaccines, they have to be stored at really low temperatures because RNA is really fragile. But they use DNA because it's more robust. So they have an adenovirus shell with the DNA for the coronavirus spike in it. So what happens? You get the jab in your arm, you have dendritic cells that are always surveying your whole body looking for anything that is abnormal. So they will see this adenovirus, it's not normal, so they're gonna try to eat it. That's what they do. So once inside the dendritic cell, you see something here is a little bit different. You see the DNA now is in the nucleus, but it's in its own separate compartment. That's because you need to go from DNA to RNA. DNA is in the nucleus, it gets processed as RNA, then the RNA comes out, uses our machinery, builds the spike proteins, and presents on the outside. Once it's on the outside, the same thing again. It's seen by our T cells, the T cells are activated, they will help the dendritic cells to become more phagocytic, they will stimulate the B cells to produce antibodies, and the antibodies will sit there and wait in case you get a real infection, that it'll be able to fight off the infection before it makes you ill. Now let's go to the third type. These are the actual proteins. So here you saw that the AstraZeneca, it had in DNA. DNA must be converted to RNA. So the Moderna and the Pfizer, they gave you RNA. RNA is then converted to protein. So the Novavax and Sinovac, they're actually giving you the protein. So the three different types of vaccines give you the three different preparations, but the outcome is the same. So this vaccine is either a subunit, so that means it just kind of cut off part of the virus and use that for the injection, or they use the virus, but it's killed or it's inactivated. So the same process, you get the jab in the arm, the dendritic cells are always surveying, looking for anything unfamiliar. They recognize that does not belong to you, it's foreign, so they eat it. Once inside the dendritic cell, there's no processing necessary because this is already protein. So they just chop it up into bits. You have the protein there, it goes onto the molecule, seen by T cells who help the rest of the immune system become activated. So that is your immune response to the vaccine. Different preparations, slightly different intercellular processes, but the outcome is the same. You have an activated immune response. So with that in mind, in the final slide, let's just look at the vaccines that are out there, the efficacy, the safety, etc. So the first one we look at is Moderna. Now the endpoint, what they were looking for in the Moderna trials, they were looking for the prevention of symptomatic COVID. So this trial were over 30,000 people. So you split them in half. It's a randomized control, RCT, a randomized control trial. So 50% of the persons are randomly put into the placebo group. That means they get something like injection with sterile water, while the other half gets the vaccine. And then they follow them forward. And they're looking for symptomatic COVID. So if the persons get a cold, a fever, runny nose, loss of smell, loss of taste, anything that suggests that they might have been infected with COVID, then they go back to the doctors and they get a test. Not everyone was tested. Prevention of symptomatic COVID. So the efficacy there was 94%. So basically the number, 185 persons in the placebo group got COVID versus 11 in the vaccine group. And that gave an efficacy of 94%, which means basically, if you got the vaccine, your risk of contracting COVID is 94% less than if you did not get the vaccine. That's a pretty good stats. They were safe, so they got a headache, fever, itch at the injection site, which you get with any vaccine. And because persons are interested in death and severe adverse reactions, they had 5 deaths. 3 were in the placebo group and 2 were in the vaccine group. And the deaths were not related to the vaccine. So one person died of a heart attack, another person committed suicide. So things that were not related to the vaccine. And we also want to know about variants. So the Moderna vaccine reports efficacy against the UK strain, but decreased efficacy against the South Africa strain. So it's still effective. You still get antibodies being produced, but less than you would get with the UK variant. And the dosing is 2 vaccines, one 28 days apart. So let's go on to the second one. Oh, they're good. So the Pfizer-BioNTech, again, another RNA vaccine. Again, the endpoint was prevention of symptomatic COVID. The efficacy was found to be 95%. And again, there were 2 deaths not related to vaccination. They had the same headache, fever, lethargy, etc. And the efficacy against the variants was the same. And their dosing is 2 vaccines, 21 days apart. Now let's look at the AstraZeneca. This is the viral vector vaccines. So their primary endpoint was also prevention of symptomatic COVID. And I have here standard dose, because if, again, you've been reading the literature, once some persons got a standard dose, and some persons got a low dose, standard dose for the first and second vaccine. But it's the standard dose that's being rolled out. They are doing trials to look more into the low dose, standard dose. But the standard dose had an efficacy of 76%. Well, you'll say, well, maybe that doesn't really look so efficacious compared to the Moderna and the Pfizer. But let's put things in perspective. The flu virus, the yearly flu vaccine, is only about 40% effective. So compared to the flu vaccine, it's very effective. And the WHO will okay anything between 30 and 50%. So 76% is quite good. The side effects, it was 1 hemolytic anemia. That means the red blood cells were breaking apart, but that was in the placebo or control group. There was 1 transverse myelitis, which means it was a problem of the nerves. That was in the vaccine group. And there was 1 person who had a fever over 40, but it's subsequently subsided. And we're not sure what group this person was in because they had not yet finished going through the entire process. Only a few people, the patient doesn't know what group they're in until the end of the trial. And this person was still in the trial. This had not yet gotten their second dose. The efficacy against variants is the same. Efficacious against the UK strain, decreased efficacy against the South Africa strain. And the dosing is 2 doses, and you can get it between 8 and 12 weeks apart. AstraZeneca also looked at asymptomatic COVID. So what they did in a subsection of the participants, they swabbed all of them, whether they were symptomatic or not, they just swabbed all of them. And they showed that the efficacy against asymptomatic disease was 16%. In fact, it was non-significant. It was like null. So this is where we hear, this is evidence that supports that the vaccine is good from stopping you getting symptomatic disease, but it doesn't stop you from getting infected. Because obviously it was 76% efficacy in symptomatic disease, but only 60% in asymptomatic disease. So it doesn't stop you from getting infected, but it does stop you from becoming sick if you do get infected. Then we have Sputnik, which is a Russian vaccine. And they looked at prevention of all COVID. So this is symptomatic and asymptomatic. Their dosing strategy was 2 shots, 21 days apart. And when everybody came back on at the 21-day mark, everybody got swabbed. And the efficacy was 91.6%. So this seems that this stops you from getting COVID, not just symptomatic disease, but they swabbed everybody and the efficacy was 91.6%. There were 4 deaths unrelated to the vaccination. The report suggests efficacy against the UK strain, but there's no data against the South Africa strain. Now this trial was in Russia only. The population were 98% white and then 2% mixed, every other ethnic group except white. And the level of diabetes and hypertension, that NCD was not really well represented within this particular trial. And then the final one I'm going to look at is the Janssen. This is the Johnson & Johnson vaccine. And this has not yet been published in the literature. It's just a report that was on the website that I was able to get the information from. And they looked at prevention of symptomatic disease, and they gave an efficacy of 66%. The safety data was not on the website, and they reported that it was efficacious against the South African variant. But we'll wait until the actual data comes out. And what's great about this one is just one single shot. So it's not the 2-day jab. So I will leave that there for now, and I'll be open to questions when it's time for the question and answer.
Thank you, Dr. Quimby. We're a bit behind, but there are some burning questions in the chat. And I just wonder whether you had any data on the sample sizes for either AstraZeneca or the Sputnik vaccine.
They were
trials.
all over 30,000, all over 30,000. So all in that same range.
Thank you. And my burning question is, of course, isn't it important just not to get infected? Because you mentioned several times in your presentation, it didn't prevent infection, but it did prevent symptomatic disease. Can you explain that?
How it does it? Or what?
Or why is that difference important?
Okay, yes. Because if you're presenting symptomatic disease, it means that you can still be infected. So it means probably that you can, if you're still infected, you can still transmit. Therefore, it means after you get your vaccination, you still have to continue the non-pharmacological intervention. So you still need to wear your mask, you still need to social distance, you still need to wash your hands properly, because you can still get infected. I mean, you are protected, but you may not necessarily protect the other person. However, I must add to that, new data is coming out from AstraZeneca that actually the transmission has been reduced by 2/3. So, I mean, we're waiting for that to come through, but they're showing actually that you might that when you're the person's vaccinated, you cannot transmit on the disease. So even though you become infected, you can't not transmit it to somebody else. And so if nobody can transmit, it's kind of like you can't get infected, right? Because if I can't transmit after a while, anybody who's infected can't transmit. It's just like if you can't get infected.
Thank you very much.
But that report has just come out.
Sure, thank you, Dr. Quimby. And I'm going to move on to Dr. Broome now. I know we're behind time, but I thought that was an important question to get out of the way. Dr. Broome, are you queued? You are queued.
Thank you very much, Dr. Connell. Just trying to, great. All right, so good evening, everyone. Good evening, panelists and all those who are listening this evening. And thank you so much for giving me the opportunity to be here and present on the COVID-19 vaccine and country deployment. Now, all of you know this picture that we have here. The Caribbean is well known for vaccination and its immunization programs. We have been a world leader for many, many years in immunization. We were the first to eliminate polio and measles and rubella, congenital rubella syndrome, neonatal tetanus. The Caribbean were leaders. The other regions followed the Americas. And this enabled us to decrease the amount of illness and hospitalizations associated with vaccine preventable disease and of course death. But COVID-19 vaccine is not about the children. At this time, it is about a different set of people. It's a different target. And we know it is about medical personnel. We know that it is about the elderly. And we know that it is about our essential services and those with chronic disease. And why is this so? Because these are persons that are either due to their job or because they're on the front line are at higher risk of becoming infected with COVID, or because of their comorbidities or the fact that they're elderly, that they are also at a higher risk for COVID-19 disease. So yes, we know the who. So in terms of planning for vaccine deployment, the first thing you have to say as a country is, who am I looking to prioritize? Because in this environment of reduced vaccine and increased vaccine demand, you have to prioritize. You can't give precious resources willy-nilly. So we know our prioritization groups, they're all over. You see the countries doing them. I've spoken about them just now. So when we know who we're looking for, then where can we find them? If we look at the elderly, We know we find them in the nursing homes, both public and private, but there's some that are ambulant, meaning that they can walk and move around, and some who are not. They're at home, they're shut in, and there are others that are in hospitals. So how do we, because we have to target these groups, how do we get to where they are and ensure that they are offered vaccine? We have to know how many we're looking for. If we don't know how many we're looking for, we don't know how many we can actually vaccinate. If we have 100 vaccines and we're looking for 300 people, we need to know that we need to further prioritize. So how many people are we looking for? What are we going to use? Are we going to use the census? If we're looking at the elderly, maybe staff lists will work with the healthcare workers. And some countries have chronic disease registries. In order to know our coverage, so we have to monitor how many of the people that we're looking for have we found. We need to document those who we vaccinate and also those who have refused, because that's the only way we can determine, yes, we have found everyone we're looking for in this cohort. Now, vaccination is one realm on its own, but we have to now do this within a pandemic environment. And therefore, we have to continue doing our pandemic activities, which includes infection control activities. So we know that persons given vaccines must wear their personal protective equipment. We must still have social distancing of persons when they go to access the vaccines. And of course, we do a lot with vaccine safety. So deploying a vaccine within the context of finding these priority groups and vaccinating, along with in the environment of having to ensure that you protect your workers and your public, can be very complicated. What are other deployment considerations? We just heard from Dr. Quimby that vaccines come with different requirements, especially with cold storage. So we have to look at the type of vaccine we're getting. Right now, a lot of the islands are using AstraZeneca, and it is quite good that AstraZeneca can be kept in the normal 2 to 8 degrees Celsius, which is the refrigerator temperature. So we don't have to look for ultra cold freezers and minus 20-degree freezers if we were dealing with Pfizer and Moderna. What are our transport capabilities? How can we transport our vaccine, our staff, our supplies to the different areas that we need to vaccinate? A lot of the islands and countries are small in the Caribbean, but some countries are very large, like Guyana and Suriname. And these are the type of logistics that really can make or break a program. And we have to look at our population density in order to determine how vaccines should be allocated from place to place. So if one area has a lot more elderly than others, then we have to say that area needs more vaccine than this area. So it isn't about sharing vaccine equally among the areas in the country, but it's determined by the density of the vulnerable population or the target population that you're looking for. Now, we're talking a lot about COVID-19 and COVID-19 vaccines, but don't let us forget that we have a routine vaccination program that still is important. The threat of other infectious diseases has not diminished. We have neighbors who have outbreaks of measles and diphtheria and other vaccine preventable diseases, and we cannot take our eye off of that ball, because while we are battling with a COVID-19 outbreak and the pandemic, we can easily get an outbreak of some other disease like measles. So we heard that there are several vaccines on the market. So we have to be very, very meticulous about if you have more than one vaccine being deployed in your country, you have to determine who gets what. We know that AstraZeneca can be given to 18 years and older, and we know that Pfizer can be given to 16 years and older. So we have to be very, very careful about who gets what and when is it time to get that second dose. So an integrated information system that not only tracks in the public sector, but the private sector, and can be used when you go onto with your mobile teams. So it is not something that is facility-based, but can be used with your mobile teams to ensure that you keep tracking your data. And of course, we have to have the safety surveillance to monitor adverse events following immunization. It is not about immunizing persons and we leave and we go on to the next. No, it is about constant monitoring, constant saying of who are we giving it to? Where are we giving it? Where are they now? How have we managed any effects? When did we give it? When is the time for the second dose? And the monitoring and the safety data is important because we must be able to monitor and identify any adverse events following immunization. So that in a nutshell is country deployment, and I would be happy to take any questions that you may have at the time of the question and answer.
Thank you, Dr. Broome, and apologies to our last two speakers, but I'm going to go into the questions because I know that a lot of the points mentioned are also in your slide set, so you may reference them in the question segment, but I will go in the interest of time to the questions. So this sounds like a question for Dr. Quimby. So ultraviolet light, can it kill the virus? Dr. Quimby, your mic may be muted.
Can you hear me now?
Yes, go ahead.
Yes, yes. Yes, it can. So if you're doing things in the lab and you want to sterilize them, want to make sure you don't have any culture and any additional growth in the culture, yes, you do use ultraviolet light.
And as I have you on the mic, don't move as yet. This is a pharmacology question, but I'm still going to ask you. Would you recommend persons with multiple environmental, food, or drug allergies to take the AstraZeneca vaccine?
Okay, so if you have food allergies, it depends on how many you're talking about. If you have food allergies, you say it's still safe for you to take the vaccine. Of course, if you have environmental allergies, it's safe. If you have a lot of allergies, like if you go outside and if you're always in this kind of hyper-inflammatory allergic state, then they'll ask you to consult your doctor and to be careful. We found that we had an anaphylaxis reactions more with the mRNA vaccines though, than with the AstraZeneca vaccine. So if you've had anaphylaxis reactions, so anaphylaxis is like a really severe allergic reaction. So it's not just like this runny nose, it's like your blood pressure is dropping, it's like a life-threatening condition. So if you've had an anaphylaxis reaction to a vaccine, any vaccine, because it might not be the vaccine, it might be the packaging that the vaccine is in, the salts, etc., then do not take the vaccine or discuss this with your doctor. But if you just have something like food allergies, or you have like allergic rhinitis, or you have those red itchy eyes, then yes, still do go ahead and take the vaccine. It's still safe for you.
Okay, thank you, Dr. Quimby. So I have a question for Dr. St. John, and it really is a broad question. How would you describe karfa's role in the Caribbean in the whole pandemic response? So this isn't specific to vaccines, but karfa's role in the pandemic response to COVID-19.
So karfa has had the remit given it through its intergovernmental agreement, and also specific remits given from the heads of government. And we have been managing this through a health security perspective. So there's not only the surveillance perspective, but there's also the perspective of getting governments to understand that those with NCDs are at greater risk. There is the guidance to member states as requested. There has been testing, not only the PCR testing, but also in collaboration with the University of the West Indies, we have been testing for the variants. There has also been regulation, vaccines regulation. So there are some questions about why are we using certain vaccines. It is best to use vaccines which have gone through an approval process. The best process is a WHO approval. And so the use of vaccines like the Covishield and the AstraZeneca made in Korea, as well as the Pfizer, is clear because they have been approved by WHO. Karfa also recognizes 5 other authorities, and therefore from that perspective, the Moderna is also recognized. We have also been working on guidance, not just for the health sector, but for all sectors and processes, including the process of elections. We've been working in partnership not only with the obvious PAHO, but also the public health agencies of the countries which have overseas territories, Public Health England, IVM, and France, and of course CDC and as well. So we've been doing quite a lot of work, and because of our connection to the European Union, we also had a pot of funds which helped us to help the countries by giving down payments for 9 of the 13 countries that have signed up for COVAX, and we have funding also lined up. Those figures were in the presentation, which we have no time for. The overall pot of money was over 2 million US. I think it's more like 3 million US. So we will also support for the countries in the advanced grouping. There are 6 countries. So we have been doing a whole range of advice within the region. We also have a tourism and health program, which allows us to support our biggest money earner in the region, tourism, in getting the kinds of protocols which allow for the balance between lives and livelihoods.
So that's a phenomenal amount of regional work. Of course, whenever I hear karfa and COVID-19, I immediately start to think variants. Have you played a role in variant testing? And
that was one of the things I said early on,
okay.
and that was in collaboration with the University of the West Indies. But we haven't just done work within CARICOM region. We've done a lot of work outside of the region as well. It's amazing the number of persons who have come to us for us to work with them as far away as the Far East. So the variants, the testing for the variants that we've been doing, the samples that have been selected from over, I think it is 17 member states, have only so far revealed the UK variant. We do testing for all of the variants of concern, including the South Africa and the Brazil. And I saw a question in the chat, but I'll wait for you to ask me about that.
No, sure, go ahead. You can go ahead and answer your question.
There was a question in the chat about if the current vaccines have been tested with variants, and the current vaccines that are in use in the CARICOM region have been. There was also a question about why are we using something that is less efficacious, and I go to the fact that in the studies that have been published and peer-reviewed, the level of efficacy of AstraZeneca has been quite high. And we have also started seeing that in countries that are using AstraZeneca and some of the other vaccines as well, there has been a decrease in the hospitalizations. as well as deaths. We are quite excited about the news that it's looking like there's also going to be a decrease in the transmissibility because of the vaccines.
Yeah, exciting news today. And before I move to Prof, I wanted to bring in Dr. Reece here, because I know that a lot of the audience must have concerns about vaccine hesitancy. I kind of see vaccine hesitancy on a spectrum from those people who will go out there and take any vaccine, and then at the other end, those people who really definitely are not going to go near a vaccine center, let alone a vaccine. So in the middle, you kind of have this group that you can massage their opinion. Michelle, do you have any comments on the barriers to vaccine uptake and, of course, vaccine hesitancy? Michelle, I think your mic is muted.
Thank you for the question, and I appreciate the opportunity to be a part of this panel. When we talk about vaccine hesitancy, it comes up all the time, but there's some other concepts that I think that we also need to think about. Before we get to vaccine hesitancy, there's vaccine confidence. And you mentioned that there are those persons who have trust that the vaccines will work, that they're both efficacious and effective. And we talk a lot about the effectiveness, the efficacy of a vaccine, but the effectiveness is so critical as well, because that deals with all the other external factors in getting the vaccine into a population. So there's vaccine confidence. Yesterday, I believe, for example, the Barbados government indicated that there were over 16,000 people who had already received the vaccine, which means, like you said, Dr. Connell, that there's some confidence in the vaccine. And then you have those who are what we may call the innovators or the early adopters, who are going to be the first people that are going to say, I want to get the vaccine. Dr. Broome talked about prioritizing, and that goes to equity. So even though there are some people who are already willing to get the vaccine, and there are some people who may be concerned, I want to get the vaccine, but I cannot get an appointment, we still have to make sure that there's equitable distribution of those vaccines. So there's vaccine confidence, and there's also vaccine acceptance, where people who are in the environment where we are trying to get these vaccines rolled out, have accepted it, have had their questions answered. They have adequate information to make an informed decision, and they're ready to go.
Yeah. Then
there's vaccine hesitancy. And I want to say this, in terms of vaccine hesitancy, we have to have clear, credible, and timely information, accurate information. We have to be transparent, because opacity and blurriness causes people to be doubtful or to mistrust the information that they're receiving. We have to provide information in a way that the average person can understand it. And then if there are questions, there's a place where they can go to get those questions answered. And then we also have to normalize fears and feelings. We cannot minimize or dismiss people's concerns about the issues of the vaccine. So where there's hesitancy, it means that people have either fears or certain feelings about it. We don't minimize it. We address them, we address their concerns, we address the myths or the disinformation and the misinformation that's out there. We avoid shaming. We can't shame people into healthy behavior. It may work short time, but it doesn't work long time. And we have to empathize. We have to empathize and understand that this is new. While we are accustomed to lining up our kids to get the vaccines before they go to school, because that's also mass vaccination. Mass vaccination of adults is brand new. And so we have to understand that this is a serious and real concern. So we have to encourage people, encourage them to even just make one step, ask the question, maybe another step, just make the appointment, talk to your doctor. So there are several things involved in vaccine hesitancy, but we also have to show that there's significant vaccine confidence and that people are acceptable to it. But the question of equity is also very important.
I'm going to come back to you because I see a very interesting question. Thanks for that conversation. I'm going to move to Prof now because I think you're the only one on the panel who can answer this question, actually. This is coming in from Guyana. And the question is, as a manager of a business, I am anxious for us to get back to normalcy. And it's hard for me to understand why people actually seem reluctant to take up vaccines that are available. Do you have a comment on this, Prof?
Okay, thanks again. I think Michelle began answering that question to some extent. In the sense that if you are in your company, if you want your employees or generally the population to take up the vaccine, then understanding people's reasons for hesitancy is extremely important. Because there seems to be a notion in some quarters that, like built on my opening spiel, people are dying, the economy is suffering, why you don't go and get the vaccine and help us get back to normal? And we know from many years of behavioral science, behavioral economics, psychology, that human beings don't make decisions that way. That decision-making process is quite complex. As Michelle said, some people are what we call innovators, early adopters. They get the product first. So you know when a new style comes out, there's some people, they're wearing it before anybody else. They are out there, others catch on much later. So we need to understand that difference and really be quite sophisticated and segment the population to understand different groups have different concerns and different messages will work for different groups. So for example, the whole notion of fear. There's a lot of evidence in behavioral economics that fear is a very good tactic for getting persons not to do something. So if you want people not to come outside and have a lockdown, sometimes fear works. But when you want people to actually take an action, sometimes fear is not the best motivator. You might need incentives. So in responding to that person, and my advice to policymakers is really to not take this for granted. This is not easy. You guys know better than I do that getting consistent healthcare behaviors is very difficult. You know, you are an internist, Kenneth, and you know that people are not compliant with their medication. So people smoke more than they should. They do all. So we should not assume that because you have safe, effective vaccines that people are going to use it. That's only part of the job. And we need to understand that problem up front and be prepared to use the full spectrum of techniques to get the maximum take-up of the vaccine. I don't know if I've answered your question.
You have, yeah, and I like that point because remember we're dealing with people who are healthy. These aren't people who are ill, who are more likely to take like an antibiotic or even some other, their insulin or something because they're motivated based on symptoms. Here you're asking a society who is at risk to take a vaccine when they're really not feeling that ill. Dr. Broome, I have a question for you that relates to the licensing of vaccines by the WHO. Can you clarify, is the AstraZeneca COVID-Shield vaccine under emergency use licensing? What is EUL?
Okay, thank you very much, Dr. Connell. Emergency use licensing means that at this time during the pandemic that the vaccines have gone through the regulatory process and have been pre-qualified to be used in this emergency situation.
And is that a lower bar then? I guess what I'm getting at is this kind of like an entry point to full approval?
this is, in a way, yes, you can look at it like that, but it was not done with any less rigor.
Of course,
meaning that the same way that they look at safety data, the same way they looked at the trials, the same way that the experts would look at all of the data that is submitted by the manufacturers, is what was done. So there wasn't any shortcut or any thinking about, well, this is needed, so we're going to let it pass.
Of course, you can't have years of data if the vaccine has only been available for a few months, can you?
Exactly.
Yeah.
So
I think that Dr. Broome has frozen, or her image has frozen. But I have a question for Joy. So there's a lot of talk about these variants, and I'm sorry to go back to it, but I almost get a sense that people think that in order for us to effectively or efficiently manage this pandemic with vaccines and the public health mitigation measures, we kind of have to do this continued surveillance for variants. Is that accurate, or isn't it?
It's accurate. And so the checking for variants, the whole genomic sequencing continues. And the member states have the opportunity to send 10 samples per week. And we have 26 member states in CARICOM. And we are checking it. There are variants of concern. The UK, the Brazil, and the South Africa variant. But we're checking for all the variants that are circulating. And so far, all we've found in the countries that we've tested is the UK variant. But it is true. The need for surveillance is very clear. And I wanted to say something quickly about this whole issue of hesitancy. Karfa is doing research to check on the reasons for hesitancy among the general population. PAHO is doing that for healthcare workers. And so we are going to try to design messages and a communication campaign for the region which responds to these concerns. I'm trying to answer the questions as I see them come up.
No problem. And so I'm glad you brought up hesitancy, because, so Michelle, one area that I think definitely would cause some hesitancy is kind of hearing from people who've had the vaccine who had ill effects. I mean, that's going to really drive some fear. I'm not going to put anyone on the spot, but I just wondered whether there are any of us on the panel who have had the vaccine, and maybe to share your experience. I'll start with myself. I had the vaccine last Friday. I did not have any symptoms up until about early Saturday morning, when I had what Dr. Quimby would describe as a very robust immune response. And with fever and the joint pains and the muscle pain, you know, these are things we need to get the public to understand, that this isn't a vaccine gone wrong, but this is an immune response. And so I opted not to take Panadols or paracetamol, and I kind of watched it unfold. And then, of course, the headache, the nausea. So this vaccine, the AstraZeneca vaccine, hasn't just had only mild effects in some individuals. But we need to clarify to the public that there's a spectrum of responses that represent an immune response. Any other thoughts on that?
Yeah, I also had, what happens is that about 12 hours after the vaccination, you will start to have something, and the something varies. I had fever, chills, headache, body ache, but I worked. I did 6 meetings during that period where I was at my worst, using Panadol. And then the next day I was fine. Usually it's short and sharp if you're going to have some effects which show that there's a very robust immune response. It's usually over 48 hours after you've had it. So
Michelle, I thought I saw your hand up as well. And you survived. Michelle, was your hand up?
I didn't have the AstraZeneca vaccine. I had the Pfizer vaccine. But because I believe I had moderate COVID-19 in 2020, I really had no side effects to mention. I had heard that after the second dose of the Pfizer vaccine that you would get some robust side effects, and I took some Tylenol a couple hours after the vaccine, but I really had no side.
So you took Tylenol. You didn't tough it out. You took your Tylenol.
Yeah.
You took your Tylenol.
If there's medication.
So Dr. Quimby, I have a question about that, because I have been asked by at least 2 elderly patients here in Barbados who've had their vaccine, and they didn't really get those symptoms. Can you explain that immune response, and should they be worried that maybe the vaccine just didn't work?
No, they don't have to be worried. As we get older, I guess with like everything else, our immune system also goes into senescence. So the immune response in an older person is not as robust as it is in a younger person. So we would expect that younger people would have a more severe response to the vaccination than older persons. So that's all right.
All right, thank you very much. And this is certainly a Caribbean audience, because I have a question from Dominica to Professor Robinson. And I saw this online today as well. I've heard that some businesses around the world are insisting that employees get vaccinated for COVID. What are your comments on that? Mandatory vaccination for employees?
Okay, well, I think the answer would be quite a short one. I think in virtually all of our Caribbean countries, that would be illegal.
Right.
So certainly the idea of requiring, but it is something that has happened around the world. I know that there's a famous story out yesterday in The Guardian in the UK where this restaurant employee was actually fired for not having the vaccine. What I would recommend instead is that organizations focus on persuading. You could incentivize people to take the vaccine. Maybe they get an extra vacation. I mean, in a sense, if this is an important part of your business model and you're quite keen to have your staff immunized, taking the vaccine, there may be an extra vacation day for taking the vaccine, a day off. These are sort of the messages that people sort of respond to. You know, people are used to these armbands. Maybe you could have some armbands that people get, I've been vaccinated, or so on. So rather than the mandatory heavy hand rule, which is likely to be illegal and counterproductive, what I would recommend is really incentivize your employees to actually do this.
Thank you. So I'm looking at the questions, and there's quite a lot of questions. There are quite a lot of questions on efficacy and the various efficacies and effectiveness. And it really would be unfair for me as an internist to pass this to a member of the panel. So perhaps I could clarify the efficacy of a vaccine, because that question is really a clinical trial question. And it's really just asking, does this vaccine work or doesn't it? And as Dr. Quimby has articulated already, anything that's over 50% certainly is approved by the United States Food and Drug Administration, and other accreditation bodies look at anywhere between 30 and 50% for efficacy. Efficacy doesn't always translate into effectiveness. The effectiveness is when this vaccine has been shown to work. You know, it drops serious illness or hospitalizations, or it prevents death. And you now put it in a real population that are taking real other drugs and are living a real lifestyle, and they're not in a clinical trial. And then you look at that population retrospectively and you say, well, how many of them are getting very ill? How many of them, how long is immunity lasting? Is the vaccine covering variants, new variants? So that it is all well and good to talk about 94% efficacy, but that doesn't necessarily translate into the effectiveness of a vaccine. And we will not have that data for a few months to years. And there may be some surprises there. I already see some signals of that coming in with AstraZeneca versus the Pfizer vaccine. So we really have to see what the non-trial results look like for effectiveness.
Dr. Connell, just because looking at the chat, and I know there are a lot of questions, there seem to be some questions around a team. Are there any conditions or any populations of persons who should not take the vaccine? Because I mean, I'm seeing a lot of questions around that team. And I know that everyone can't keep up with the chat. So I don't know if one of the clinical persons could make a maybe, are there any conditions, syndromes, or groups of people, pregnant women, etc., that are especially at risk? Maybe someone
so the relative and absolute contraindications for taking the vaccine. Doc, any of the clinicians, do you want to take that response? Dr. Broome, I see you smiling, and I'm going to interpret that as a yes.
Yes, I can take that response. So the recommendations that PAHO and WHO follow come from a body of independent experts. These are experts in areas such as immunology, public health, pediatrics. They are experts in a wide range of fields, and they look at all of the data and then make their recommendations, which then WHO follow and PAHO follow as well. In terms of strict contraindications, the only strict contraindication is if you are allergic to any component of the vaccine, or if you have had a severe allergic reaction to the first dose of the vaccine. Those are the two strict contraindications. It is true that there are some groups of persons who have not been trialed with the vaccine. So we have pregnant women, we have children, we have groups that have obviously were not included in the first set of clinical trials. But the recommendation is, as long as you are in that priority group, and that means you are at high risk for severe COVID, which means hospitalization or even going down to death. If you are at risk for severe COVID and you are in any of the groups, it is advised, it is recommended that you take the vaccine. Yeah. Because the risk of severe COVID, when you weigh it with the vaccine just comes out on top. It is safer for you to take the vaccine.
Thank you, Dr. Broome. So I have a more immune-dense question for Dr. Quimby, and it kind of relates to the history of vaccines, for instance, the live attenuated vaccines and the dead vaccines. And these are almost new platforms, from my understanding, mRNA and even the viral vector vaccines. What are your comments on this new generation of platforms?
Well, they're newish. So, I mean, persons think they're like just fresh off the block, but they're not that new. They're new compared to the inactivated and the killed ones. But if you remember, we had the SARS and MERS a few years ago, and these platforms were actually being developed during that time. But in order to have a clinical trial, you need to have the disease still circulating so that when you get the vaccine, people can get or not get the disease. But MERS died off really quickly, so they weren't able to have a clinical trial. But those vaccines were being developed since around that time. And it's easier and quicker, I suppose, to develop a mRNA and viral vector than to have the heat killed. So basically the heat killed is the virus that you've killed. So you can imagine you have to grow all of those viruses and then kill them, and but it's easier than to just get the genetic code, and faster to just get the genetic code and use it that way to vaccine. I will use an analogy. If you were going to Bridgetown 50 years ago, you might have to go by walk or by donkey cart. It will take you 12 hours to get there. Now you can hop in our car and it takes us half an hour to get there. So it's not that things were rushed. It's just that we have new advances that help us to do things a bit faster.
New platforms. I see a question here which I can take quickly. Is it possible to that if you're allergic to NSAIDs, is it safe to use the AstraZeneca vaccine? The answer to that is yes. We don't have any clinical evidence that aspirin allergy or NSAID allergy would predispose to an allergic reaction to a component of the AstraZeneca vaccine, certainly Covishield. Dr. Reece.
Yes.
can you paint a historical perspective? Because there is certainly an ethnic hesitancy that's involved as well towards vaccines, and the Caribbean is therefore no exception.
Correct. So inclusion of minorities, particularly persons of the Black race, in clinical trials and research studies has been low over the years and still continues to be low. But historically, there have been some studies that have been conducted that place Black persons at risk. They were unethical studies, given, for example, what we call the Tuskegee syphilis study, where Black men were infected with syphilis, and even though penicillin was developed, that study continued for 40 years. And these persons didn't know that they were in a part of a study and they were actually being given the treatment. So some of that is some stuff that has happened. But when we start looking at, and it's a real concern, I think someone talked about the Sputnik vaccine, that the population that was studied were predominantly white persons. So those are real concerns.
Yeah.
But we're doing better in the scientific community in terms of including more minorities in our studies.
Sure, thank you. I have a question that kind of touches two bases here. It's from Paula Williams. So is there any information on what is the actual effectiveness for immunosuppressed patients? And this person obviously has is immunosuppressed, and she's concerned about the effectiveness of possible reactions due to illness. Anyone? Any of the medical colleagues?
I think I answered that in the chat already.
I thought you did. I just wanted you to repeat it here. Go ahead.
Oh, sorry, repeat the question again, please. I was just furiously trying to answer questions in the chat.
Yeah, the immunosuppressed patient. I mean, that's a big concern. And you could also say that elderly patients are slightly immunosuppressed as well. So what is the fear for vaccines if you are immunosuppressed?
Thank you. Yes, so if you're immunosuppressed, if you remember those diagrams I show you, it means that your immune system is not responding as it should. So the vaccine can't do you anything because the vaccine is not live. Okay, remember, it's just bits of the mRNA, bits of the protein. It's not a live vaccine. It cannot replicate. So the vaccine cannot infect you. Because you're immune suppressed, it means that you probably would not mount as good as an immune response to the vaccine as a person who was immunocompetent. So the vaccine can't hurt you, but you may not get the efficacy as immunocompetent persons are, because your immune system just can't respond because you're immunosuppressed for whatever reason.
So the paired question to that, of course, and I already know the answer, it's going to always be consult with your healthcare professional. But the paired question to that is, if I am on an immunosuppressant drug, then should I stop it just about the time when I'm taking my vaccine?
Yeah, no, please consult with your primary care physician. Do not stop your immunosuppressant drugs, please.
Absolutely, absolutely. We don't want the School of Business and Management to get sued. So this question, again, Kim, is for you. Interestingly, it looks at the design of the AstraZeneca, and I thought this would come up. The article on the AstraZeneca vaccine reported a low dose and a standard dose regimen, more than 8 weeks apart. That was at least 90% efficacious. Can you comment on that? Or is that just a study design phenomenon, or is that a real phenomenon? What is it in your opinion?
Yeah, so part of the group, I think it was the UK group, got the low dose, standard dose, whereas all the rest got the standard dose. And I think that happened inadvertently. Yeah. And they did show that the low dose standard dose is actually more efficacious than the standard dose. However, just a small number of people who got the low dose standard dose. So it's a standard dose that's being rolled out. But they're actually doing another trial now with the low dose, standard dose to see if that result was actually real.
Really true, and not just a signal. And I think that's important. Now, another question here, which I think any of us can answer because this has been announced, I think, the dosing schedule for the Oxford-AstraZeneca vaccine second dose, I believe a statement had come out stating that this will now be given at 10 weeks, as opposed to the initial 4-week that was advised initially. And obviously this would have come from the ad hoc committee recommendation on vaccines. This dosing schedule change occurred. Okay, I have another question here, which is, I'm jumping through the chat. Okay, so a person between the age of 40 to 50 years received their first AstraZeneca vaccine. Within 15 minutes, started experiencing itchy eyes, skin, tingling sensation in the hands and muscle. This does not sound like me. Needed an antihistamine injection and oral antihistamine for about 7 days. No previous history of reactions to vaccines, and only a history of allergy to sulfur-based antibiotics. Should that person receive a second dose? Anyone on the panel?
Again, I think that these are questions that individuals need to have with their healthcare provider. I think we would be remiss to try to answer a question so specific to an individual, because persons, we don't have the full picture or the whole history of this person. And I don't think that that's a question that we can answer.
Great. Okay, and that's a reasonable response. So I have a much longer question now. It's not a concern, or is it not a concern for the mRNA vaccines, lipid bilayer, and the adenovirus vaccines that they may trigger a body's own immune reaction to reduce their efficacy? I guess, Kim, again, this is coming at you. Is there a concern with the new mRNA vaccines, with the lipid bilayer, and of course the adenovirus vector vaccine, that they may trigger the body's own immune reaction and decrease, so not what it's meant to do, but actually decrease the efficacy?
I am not sure. I'm not following that question, because I can't see how that is happening. So I'm not sure what the person is really asking. I'm not understanding the question. How would it, I can't see how it would.
I think the question is asking whether the component of the vaccine, whether the viral vector or the lipid capsule for the mRNA vaccines, whether that has the effect of causing an immune reaction to actually weaken the efficacy of the vaccine.
No, unless that the person is asking about the chimpanzee adenovirus vector versus the human adenovirus vector. So that's the only kind of thing I can, think that they'd be asking about. So no, there's nothing in there that will decrease the response. I mean, if it's something that's foreign, and when something foreign enters your body, you have your dendritic cells that recognize that it's foreign, and your body will respond to anything that's foreign and try to get rid of it. It's just how your immune system is built.
Okay, so this question is for Dr. St. John or Dr. Broome. So is it true that Switzerland from early this month is not approving the Oxford-AstraZeneca vaccine, stating that there is a lack of data to reach conclusions on the efficacy, and states new studies are required for additional data on the vaccine's safety, efficacy, and quality? So that's the UK Oxford-AstraZeneca vaccine and its approval in Switzerland.
So I take my time from WHO, and I have been studying the report by the SAGE group that looked at how AstraZeneca vaccine should be used. And they have not recommended that it shouldn't be used over 65s. So even if Switzerland feels that way, I am going by what WHO has put out, as it has the global remit. Switzerland has the remit for Switzerland.
I think that's
so. From that perspective, I can't say that their decision is wrong, but I will say that I will follow the WHO guidance.
I think that is reasonable. And Karen, here's a question that I knew someone would ask. What percentage of a country, although Barbados is used as an example, but what percentage of a population should be vaccinated for vaccine in order for it to be considered that the population has reached the herd immunity threshold?
Right, and this is
Love to hear the answer.
that's correct. This is $1 million question. There is a lot of conjecture about,
course.
oh, maybe it's 70, maybe it's 85, but we are unsure.
We not know.
We don't know. We don't know. So again, to the entire panel now, do we need to get vaccinated quickly? Is there any benefit to doing this process as quickly as possible? Or can we just kind of have a slow wait and see response over an entire year? Comments?
Ken, I sort of think of this through my lens as a financial economist. When you make decisions, you look at risk-reward trade-off.
Mm-hmm.
I think it's pretty clear to me that the benefits from the vaccine in terms of our lives and our livelihoods appear to significantly exceed any risks from the vaccine. So there are risks, So vaccines, some of them are new technology, so to speak. We don't know all the outcomes. We don't have all the answers. But when I look at the risk-return trade-off, it's clear to me that we should all seek to get vaccinated as soon as we can.
Okay, thank you very much. Now I'm looking at the time, and it's actually, this hour and a half has gone so quickly. It is time for closing comments. Wow. So in the reverse order, I'm going to request closing comments. First from our visiting Barbadian, Dr. Reece, go ahead.
Yes, if there's nothing else that persons take away from this webinar, is that there is good vaccine safety. The COVID-19 vaccine will save lives and it will prevent severe disease. Wherever possible, if you have questions, speak to your healthcare provider and make the decision. But at least take one step. Make the appointment.
Thank you. I like that closing point. Make the appointment. And next, Dr. St. John.
We are living in historic times, and I have never seen, even though I would have been involved in the Barbados response to the H1N1 pandemic. Remember, that was a pandemic. Mm-hmm. And even though I have done adult MMR catch-up campaigns when I was the immunization manager, mm-hmm. I've never seen anything like the way in which Barbados and the other countries in the Caribbean have geared themselves up and been prepared to deliver the vaccine. Taking the vaccine, if you so choose to do, is perhaps the Caribbean's best chance of finding the good balance between lives and livelihoods, returning to economic activity, not just in tourism. And so for those of us who have been given the privilege of access, because I can tell you, access is hard fought for. That was part of my presentation. The heads of government have been fighting. Those of us who have been given the privilege of access, once we want to do it, should not walk briskly or even run to get the vaccine.
So walk briskly or even run. I like those comments. So Dr. Broome?
Final comments. My thoughts are, the vaccine protects you, the person who goes to take it. You will also be able to protect those in your household. Remember, the data is coming out saying that the vaccine decreases your viral load. So when your viral load gets decreased, even if you get COVID after the vaccine, your viral load is very low. So that means that even if you do get sick, it will be very mild. You will be less likely to pass it on to your mother, your father, your grandparents. You'll be less likely to pass it on to your neighbor who may not be able to get the vaccine because of some issue. Don't just do it for you, but do it for your family and your community.
Absolutely.
Thank you. All of you are closing with some fantastic sound bites. Don't just do it for you, do it for your family and your community. Dr. Quimby?
Thank you. So thank you for inviting us into your homes, and thank you for this very robust discussion that we've had. I know over the past few months, you've been inundated with information, some true and some not so true, and some downright false. I have distilled for you the information as best as I know it. I've tried to do so, honestly and openly and transparently. And I hope that you will take this information in the way it has been delivered, and that it will help you to make the best decision for you. Do have a good night.
Thank you very much. And last words, Prof?
Again, thanks to the audience for joining us. We are not here to sell you anything. This is an adult audience. The vaccination is a choice. Our lives have been devastated. Think of all the children who have not had normal school for 12 months, the crisis with CXC, those persons who have died alone with their families not next to them, people who have had to endure, we love our big funerals in the Caribbean. People who have died from other diseases haven't been able to have normal funerals. There are risks to the vaccines out there. There is a lot of uncertainty, but the risk-return trade-off, the risk from the vaccine, to the best of our knowledge, appear to be less than continuing with this catastrophic situation we are facing in terms of our lives and our livelihoods. So based on the best information we have, it would seem that the vaccine is the best option that we have now to get back to some sort of new normal.
Thank you, Prof. And I'm going to just close with the comments which really echo all of your responses, and that is, making this decision about whether to take a vaccine or not to take a vaccine is really balancing risk, which has to be balanced at an individual level. Am I going to deal with the risk of an unpredictable disease like COVID-19 versus the very small risk associated with taking any vaccine, including some of the COVID-19 vaccines? And then what about the population risk? What about the risk of transmission and the fact that a slow vaccination process may actually mean that more variants will evolve and we will be in this cycle for a very long time? And so as we have this discussion about which type of vaccine is better for me, I think the take-home message has got to be, we all should get vaccinated as soon as possible with any safe and efficacious vaccine. Think of it like a wildfire that's burning rapidly. We shouldn't be arguing over what type of water we're using to out it. We should just get things out as quickly as possible. And the nuances and sophistications and changes in vaccines over years, I'm sure, will then take us to a much better level of outing specific fires, but everything at least would have simmered and be under control. We've had such interesting questions. We will get back to many of the questions on Facebook, as well as some of you have emailed us in. This has been an exciting afternoon or evening of discussing vaccine. I hope this K-Phil School of Business and Management invites us back to this space. Thank you very much, and stay safe. Remember, the mitigation measures are still critical. Wash your hands, wear your masks, and now that's possibly 2 masks, social distancing, and consider strongly getting the vaccine. Don't walk, but run. Thank you.
Thank you.